Surgical endoscopy always includes diagnostic endoscopy. Biliary endoscopy, intraoperative, cholecystoscopy. The physician performs a biliary endoscopy during the same surgical session as other biliary procedures. The physician advances an endoscope through the previously made abdominal incision. With the endoscope, the physician is able to directly visualize portions of the biliary tract, which may be filled with contrast medium for identifying the common bile duct, biliary tree, and gall bladder, including areas of abnormality, stricture, or obstruction, under separately reportable fluoroscopy. Biliary endoscopy, percutaneous via T-tube or other tract, diagnostic, with collection of specimen, S, by brushing and/or washing, when performed. With biopsy, single or multiple. With removal of calculus/calculi. With dilation of biliary duct stricture, S, without stent. With dilation of biliary duct stricture, S, with stent. The physician makes a small incision in the abdominal wall. The physician advances an endoscope through an opening in the abdominal wall or through a T-tube inserted through the abdominal wall into the common bile duct. With the endoscope, the physician is able to directly visualize portions of the biliary tract, which may be filled with contrast medium for identifying the common bile duct, biliary tree, and gall bladder, including areas of abnormality, stricture, or obstruction, under separately reportable fluoroscopy. The physician may collect specimens by brushing and/or washing, separate procedure. The endoscope is removed. The T-tube is withdrawn and the defect in the common bile duct is sutured closed. The tract, peritoneum, and abdominal wall are closed with layered sutures. In 47,553, the physician advances biopsy forceps along the tract or T-tube to obtain single or multiple biopsies under direct endoscopic visualization or with the use of fluoroscopy. In 47,554, calculi are identified and removed. The endoscope is removed. The T-tube is withdrawn and the defect in the common bile duct is sutured closed. The tract, peritoneum, and abdominal wall are closed using a layered technique. The physician advances a balloon-tipped catheter through the tract or T-tube so that it is above the site of the duct stricture, inflates the balloon and draws it back through the site of stricture to achieve dilation. This procedure may be repeated until optimal dilation is obtained. The endoscope is removed and the tract, peritoneum, and abdominal wall are approximated. The endoscope is removed. The T-tube is withdrawn and the common bile duct is sutured closed. The abdomen is sutured closed. The physician advances a balloon-tipped catheter through the tract or T-tube so that it is above the site of duct stricture, inflates the balloon and draws it back through the site of stricture to achieve dilation. This procedure may be repeated until optimal dilation is obtained. The physician places a stent to prevent future stricture. The endoscope is removed. The T-tube is withdrawn and the defect in the common bile duct is sutured closed. The abdomen is sutured closed. Mediastinoscopy includes biopsy, IES, of mediastinal mass, e.g., lymphoma, when performed. With lymph node biopsy, IES, e.g., lung cancer staging. Endoscopy, surgical, including video-assisted harvest of vein, S, for coronary artery bypass procedure. A surgical vascular endoscopy is done that includes video-assisted harvesting of a vein for a coronary artery bypass. The physician makes a portal incision above the saphenous vein. The endoscope is inserted into the incision and visualization occurs on a video monitor. CO2 gas is insufflated through the endoscope and dissection is made to the vein. A cannula is inserted and a portion of the vein to be removed is released from the surrounding structures. The vein is tied off above and below the portion of the vein to be removed. The vein is removed through the harvesting cannula. The endoscope is removed and the incision is closed with sutures and strips. The portion of the vein removed is prepared for use in cardiac bypass surgery. Use of ophthalmic endoscope. The ophthalmic endoscope is used for diagnostic purposes or in conjunction with another procedure. The endoscope is properly focused prior to the procedure. Once prepared, an 18 to 20 gauge endoscopic probe tip is inserted through a sclerotomy site. The physician maintains a working distance of 2 to 10 mm to allow visualization of the internal eye structures. It is commonly used when visualization is impaired by pathological changes or poor pupillary dilatation. Once the procedure is complete, the endoscope is removed and the physician may close the incision with sutures. A topical antibiotic or pressure patch may be applied. This code is used in addition to the primary procedure. Endoscopy, wrist, surgical, with release of transverse carpal ligament. The patient is placed supine with the arm positioned on a hand table. Endoscopic release may be accomplished by a 1 or 2 portal technique. In a single portal technique, a small, 1.5 cm, horizontal incision is made at the wrist. Using a 2 portal technique, 2 small incisions are made, one in the palm and one at the wrist. The palmar skin, underlying cushioning fat, protective fascia, and muscle are not cut. The endoscope is introduced underneath the transverse carpal ligament. The endoscope allows the physician to view the procedure on a monitor. A blade attached to the arthroscope is used to incise the transverse carpal ligament from the inside of the carpal tunnel. The instruments are removed and the portal, closed with sutures or strips. A splint may be applied. Endoscopic plantar fasciotomy. The physician performs a plantar fasciotomy using an endoscope. The patient is placed prone. After administering a local anesthetic, the physician makes a small incision to create a passage for the endoscope. Other incisions are made as needed for additional instruments. One or more transverse divisions of the contracted and fibrotic cord, of plantar fascia in the foot are performed for therapeutic release. The instruments are removed and the wound closed with simple or layered sutures. Vascular endoscopy, surgical, with ligation of perforator veins, subfascial, SEPS. Subfascial endoscopic perforator surgery, SEPS, is performed as a minimally invasive way to treat patients with chronic venous insufficiency, CVI, of the lower extremities. Incompetent calf perforator veins are ligated in this procedure. Perforator veins are an irregular group of veins growing as tributaries of the greater saphenous vein, which connect between it and other veins in the lower leg. They are considered incompetent when the direction of blood flow within the perforator vein changes upon applying distal pressure. SEP is carried out under regional or general anesthesia. A rollover tourniquet technique is used to exsanguinate the leg and a single stab incision is made over the medial aspect of the calf through which the operating telescope is inserted. The subfascial plane is created with blunt dissection and maintained open by insufflating with carbon dioxide gas at low pressure. The perforators are identified and ligated, or transected, with a 5 mm ultrasonic scalpel. Patients may be given elastic stockings to wear for the next 2 weeks. Surgical vascular endoscopy always includes diagnostic endoscopy.